We've only got one mic, so we'll have to stand next to each other to introduce ourselves. So I'm Philip Howard. So I'm an antimicrobial pharmacist from Leeds. This is Stephen hiding behind the thing. I will talk into my tie.
Hello. Hello, Ty.
Hello, Ty. So we're going to do a bit of a double act, and those people who sort of know me might think, what the hell does he know about ANTT? I was asking myself the same question only a short time ago. So what we're going to do is we're going to do a double act. I'm going to do the first bit of it. Stephen's going to do the second half of it, which is probably going to be a lot more questions and answers. So we're going to talk about antimicrobial resistance, but we're going to try and focus on reducing unnecessary antibiotic use through ANTT and antimicrobial stewardship. And I'm going to base my side of it very much on, we've not been bribed or corrupted by anybody. That's just to tell you on that. So I'm going to try and focus my bit very much around the role of either the ward nurse or the infection prevention control nurse, doing a bit more around stewardship. Historically, it's been very much around, I do infection prevention control, pharmacists do antimicrobial stewardship, anyone does sepsis, we give antibiotics to everybody, so anyone can do it. So I'm going to focus mine around that and really just come up at the end of it, describe how ward or infection prevention control nurses can support stewardship. And then Stephen's going to talk a bit more around what ANT is and how you can utilise it to help reduce healthcare associated infections. So hands up if you are a nurse. Hands up if you are a doctor. Hands up if you're a pharmacist. God, more pharmacists than I thought. I apologise to the pharmacists in advance for what's going. Yeah. So a couple of bits about antimicrobial resistance for you. So first of all, antimicrobial use, certainly in developed countries, drives resistance, especially broad spectrum antibiotics. So one of the reasons we want to try and reduce antibiotic usage. Poor hygiene, whether it's hands, mouths, genitals, whatever, basically spreads bugs, and the ones we're more worried about, resistant bugs. I don't know if you know, the UK has the highest antibiotic use per head of population in hospitals of any country in Europe. Did you know that? No. So we're not very good. Did you know that 25% of hospital antibiotic use is actually for hospital-acquired infections? Does that surprise you? So when we've got some of these targets a little later on about reducing hospital antibiotic use by 5% over 3 years, and you can see the range that's been sort of given, including a 10% reduction in broad spectrum antibiotics, and I won't go into the detail of what watch, access and reserve antibiotics are. There's a lot that we can do knowing that a quarter of our usage is actually for hospital-associated infections, and this is why this is really important. And this is why, for me, as an antimicrobial pharmacist, prevention is better than cure. And I would much rather see efforts throwing into prevention to avoid people getting infections in the first place and then having to use antibiotics and sometimes inappropriately on there. Bet you didn't think you'd hear that from a pharmacist, did you? So, is there any evidence for antimicrobial? Oh my gosh. I'll write out antimicrobial 100 times on the way home. It was spelt correctly earlier. So I was on the NICE committee eons ago and disagreed with the definition of antimicrobial stewardship because it didn't contain the word patient, which is essential. But antimicrobial stewardship is about improving outcomes for patients with infections without causing harm or increasing antimicrobial resistance on there. And I've already told you already, 1 in 5 patients will be harmed if they get an antibiotic. So there's some good evidence that you can decrease mortality by about 1/3 if you follow guidelines. You can decrease mortality if you actually send anything away to the lab and you adjust your treatment based upon the results. So you get a 2/3 reduction in mortality. And if you switch from IV to oral antibiotics, you can decrease your length of stay, save money and increase cure rates. And a paper that came out, well, it's almost 2 years ago now, by Tacanelli, or Bohr was the lead author, was showing from the meta-analysis you can actually reduce gram-positive resistance by 43% and gram-negative resistance by 28%. And you can see the problem organisms of MRSA and carbapenem-resistant Enterobacteriaceae by large amounts. So there's some good evidence to support doing this on here. Now, I'm sure many of you might have seen this whole thing of start smart, then focus many times. And the start smart is all about treating patients promptly. It's not a golden hour. It is a golden 3 hours if you look at the evidence base for it. And we've been driven to overuse antibiotics. We've doubled our use of antibiotics since the sequin has come in. And we may debate at length whether we've actually seen any improvements in survival rates. The important things is about taking allergy histories and following your guidelines and then coming up with indications on there and sending off blood cultures. And one of the things that you probably don't know about blood cultures is if you actually send off a blood culture before you actually give an antibiotic, you can actually get a positivity rate of about 34%. If you, in the same patient, you give an antibiotics, wait 90 minutes or up to 90 minutes, take blood culture and send it away, it drops to 19%. So a really key bit is here, you ask that question saying, take blood cultures, give antibiotics, and get it done in that order, really importantly. And if you can get your blood cultures on incubation within 4 hours and speed that whole process up, you'll get much quicker results that you can then de-escalate and help the patient. The other bit is around false allergy labels. You may not be aware, having an allergy label is bad for you. Okay, really bad for you. We published only recently in Leeds, up to 85 extra deaths, my hospital, extra 85 deaths per year estimated by actually having a false allergy label on there. Because you get second choice antibiotics with lots of side effects. It drives healthcare acquired infections, so 35% more increase in C. diff, 55% more in MRSA. And it drives broader spectrum antimicrobial use such as meropenem. And you can often safely delabel most patients, and you'll see some stuff coming through there. Then, 48, 72 hours, we get some back from the lab. You either stop, switch to oral, change antibiotics, or continue. And how often do you hear just one more day? Anybody? Yeah, just one more day. Well, there's good evidence. One more day is bad. One more day in ICU, every day you get an extra 8% increase in resistance with using ceftazidime or piperacillin tazobactam, or 2% with meropenem. You're driving resistance in those patients. Surgeons, we had a lovely surgeon, Giles, earlier. One more day. So look at the excess days of prophylaxis for driving. Number needed to harm for acute kidney injury goes from 9 as you increase it over 3 days and 4, but with C. diff, 2,000 patients you have to treat before you see a case of C. diff for 2 days, drops down to 50 when you get over the sort of the 3 days, so 4 days and beyond mark. And so that's one of the real sort of impacts that we've got on there. And we know, good press says you should always document the reason for staying on IV antibiotic after day 3 and the outcome of the IV to oral switch tool. That is something that was part of a sequin that should be used routinely. So, how can a good day 3 review of empiric IV antibiotics lead to hospital, improved hospital working? Forget resistance. This is about harm. This is about better patient flows going through there. If you switch from IV to orals, you can decrease the length of stay by 6 days and you can free up masses of beds. How many of you spend your days drawing IV antibiotics up? Yeah. Do you hate it? Yeah. So some work that I did before, taken from the literature, shows that you can actually free up in a 1,000-bedded hospital 6.5 shifts a day by switching those who meet the criteria onto orals and saving about $500,000 a year. And then C. diff, we know, is linked to longer courses of broad-spectrum antibiotics, especially things like piperacillin tazobactam, carbapenems, but the mortality rate, which is quoted around about 20% at 28 days, when we've done some real-world evidence, 30% of patients who've got C. diff are dead at 3 months in Leeds, and it won't be any different in your hospitals. It makes old people go downhill really quickly and die. We see less phlebitis, and we certainly know that 15% of MSSAs and MRSAs are related to devices. And one of the challenges I've said for the ward nurses is make sure there's a list available for the wards on who's on antibiotics. And if you say, it's not my job, it's a doctor's job, just think of making up IV antibiotics, making up patients dying of C. diff, okay? Change those sheets and everything else like that. That's why it's important. So, what's the role of the nurse in stewardship? Well, trying to get shortest duration treatment on the wards, trying to get that switch from IV to oral, trying to make sure we get first doses in a timely manner, making sure sampling's appropriate, so not sending off urines in over 65s, making sure bloods are taken for therapeutic drug monitoring at the right time. How often do we see them at the wrong time? Getting patients referred for OPAT therapy, and then education of nurses, other nurses on the ward rounds. And the beauty about nurses is they have lots of long-term memory and they don't turn over as quickly as doctors and other staff on there. And I would say the modern day infection prevention control nurse should have a role that covers stewardship, sepsis and infection prevention control. And the same would go for the pharmacists. We should all be delivering the same standard sort of message. Some will have a bit more expertise, but we should be going out educating wherever we can. So we were asked by some nurses who were interested in this to set a forum up. So there's a forum, free to join, free to use, nursingAMSforum.co.uk, and there's lots of resources on there. So feel free to have a look at it if you're interested. And then my final slide is some work that the Institute of Health Improvement, which from the USA did, which was about using safety huddles for education on antimicrobial stewardship and resistance. And some people locally have called them either a druggle, because it contains drugs, or a buggle, because it's about bugs. And basically, hands up if you do huddles at ward rounds on your wards. Yeah, most of you probably should do. So it's based on the safety huddle. So 5-minute structured meeting each day to improve safety. You make up your own priorities, but these are the ones that are guided on there. So try and make sure antibiotics included in all the things on there. And I would say especially IV antibiotics included on there. And we get people to just do 4 slides maximum. You can hold them up as a piece of paper, just saying, and often that might be things like a hot topic, prescribing of the week, and then some good prescribing, and maybe some weekly prescribing charts. Really simple to do and can have an impact on what you're doing. So there's some druggles and buggles. And now for something even better.
Some people would call this session winging it. I wouldn't go that far. I would say that I thought this was quite a mixed audience. You've had a bit of a message and an update about ANTT this morning, and I can talk about ANTT very, very easily, depending on what you want to hear. So I thought what we'd do, I've got plenty of slides. I can revert to showing you stuff, but I thought I'd start off with an opportunity for some questions, which we didn't have this morning, and maybe a straw poll on what might be useful. So have a think about it. I could go over, and we haven't got loads of time, but I could give a quick overview of what ANTT is and just refresh the framework. What is different about ANTT, for example, to aseptic techniques. So that would explain the ANTT framework. I could talk about ANTT competency, the process of getting everyone competency signed off. Or I could talk about ANTT implementation, how you implement ANTT, whether that's in a small team or a supersized hospital or a country. So first of all, while you're thinking about that, I'll do a little vote in a minute. If we're really crazy, we could just go for all 3. But are there any burning questions? Okay.
I just want to say something.
Oh. Yeah.
What I want to say is that when I started training as an SRN 40 years ago,
Yeah.
we had to do an aseptic technique as part of our training.
Yeah.
If we failed it 3 times, we were assessed and trained for it. If we failed it 3 times, we booted out. So I don't understand why it's dropped off the nursing agenda. That's what I don't understand.
I think we'd probably all be the same. I think, things come and go, don't they? They come around. In my mindset, what I was kind of alluding to this morning was that I think we need to build on the foundation ANTT has put out there. For the first time, you have a single framework, which obviously has a lot of efficiencies, us all talking the same language and other benefits. I would like to see a a mandatory competency assessment of aseptic technique using ANTT in the NHS that was mandatory, just like CPR. But I don't think we'll answer the why now, but I share your pain.
Yeah, and there's a lot of pain actually.
So we annually assess all our nurses on ANTT, and they all pass, but then when you watch them in clinical practice, that 30 seconds is where you see that fading come back.
Sorry, I missed the 30 seconds
Sorry.
bit.
You know, in the cleaning tab,
Yeah.
that's where you see sort of people cutting corners in practice.
Yeah,
So they all
absolutely.
do it beautifully when they're annually assessed,
Yeah.
but it's the clinical practice.
So part of the, obviously that kind of goes for any competency. But interestingly, part of the ANTT competency is a theoretical test within the competency. I don't mean separate e-learning. I mean during the practical OSCE of the official sign-off of ANTT, there are questions. So you can't just kind of go in half asleep and do something you've been doing for 20 years. You will be asked to articulate that in ANTT terminology, which certainly helps embed the process. These two ladies had a question. Oh, three. That's all right.
So I've moved away from a big NHS trust, and I've heard that they now don't use gloves doing ANTT, and it's a cost because of the cost implications.
Yeah.
Just wondered. I don't know ANTT's changed. That's why I'm here today.
Okay.
What do you think about that?
It's quite topical. Infections cost too. The key message on the glove front, because it's kind of a bubbling debate that's going on. It's not a big thing, but it's a bubbling debate. And the important message is this is a non-issue for ANTT. Some people have tried to wed the two together and say, well, ANTT takes this position and therefore there's a problem with ANTT going forward if you take that view. That's nonsense. ANTT is fundamentally about technique, process of aseptic technique, the principles, the key part protection, and so on, which I might explain if we go over the framework. The infection control bits, which are obviously related to hand hygiene, PPE usage, we take from stakeholder guidance like EPIC 3. So if any of those bodies want to stop giving it that and give it some guidance, then we would happily follow. But we do think that going around to conferences telling frontline staff not to wear gloves without any accountability behind you in terms of your organisation's guidance in written form and evidence laid out, frankly, I consider reckless.
And repulsive.
And repulsive, did you say?
To wear gloves.
Yeah, well,
Doing ANTT.
yeah.
Not like
Well,
supposed to, I mean, it's not. Sorry, it's not only the matter of not giving information to the patient, but protecting yourself.
yes. Well, yes.
I don't know.
Say something further before you answer his.
No,
Yeah.
I'm done. Sorry.
I would just very quickly say, I kind of get your point, but it's perfectly possible to do a lots of aseptic technique procedures, simple ones, without gloves, in theory. Absolutely possible. Because in theory, if you're wearing non-sterile gloves, the whole point is you're not meant to be touching the key parts. So you can take that back and think, well, why are you wearing gloves? There's a discussion around that, why, but it is perfectly possible. So we're not saying you have to wear gloves or you don't have to wear gloves. We're saying we want that resolved, and then we'll blend it into our guidance. Sorry.
No, that is basically it.
Okay.
It's because, for
Yeah.
example, our argument is gloves are dropping on the floor. I see people shuffling back
Yeah.
inside the box.
Yeah.
Looking up and looking, well, then what's going on
Yeah.
with gloves?
Yeah.
The gloves, yeah.
Correct.
Tucking away,
Yeah.
etc.
Yeah, there's a whole load of human issues around that. I think the sticking point for me and many others is cost regulations. Now, they have been poo-pooed by some, but I think you have to be very careful because organisations deal with risk in policy and they make black and white decisions. They don't say to their 6,000 staff, pop along, draw up your drugs, decide which ones are dangerous, and then do what you like. What they do is they make rules. And the health and safety requirements are legal, a requirement of organisations. And if you have a staff member that decides is told not to wear, don't need to wear gloves, and they come into harm from a drug, Now, it might sound high risk, but we actually had somebody at UCH who dropped down and had a massive anaphylactic reaction drawing up drugs, and she left nursing because they could never find out which one it was that was the problem. So things happen. And I just think, and that's obviously a very unusual situation, but the COSH regulations are clear. It's a health and safety law. Every drug comes with a COSH data set, and nearly every drug, even your common antibiotics, like piptazobactam, say wear gloves and wash your hands copiously if you get drugs on. So I'm not saying no, I'm just saying it needs tidying up. COSH needs resolving so organisations can write safe policy. Yeah? Okay. Right. You've had a little time to think. Let's have a quick vote. What would be most useful to talk, an overview of the framework, competency assessment or implementation? Bearing in mind, I'm not in a desperate rush to go, so I can always stand over there and do some small groups as well, until you all get bored. So let's have a quick vote. Number 1 was a quick overview of the framework. Talk about competency is number 2. And 3, how to implement. Oh, blimey. It's all a bit close.
Can we do 2?
Pardon?
Can we do 2 or can we have time?
I'll whiz through the framework to give you a flavour, and then we'll talk about competency assessment, okay? And if anyone wants some guidance on implementation, then my email address is probably the best way to go, and we can have a dialogue, and we can send you some stuff. I'm trying to find out where we are. Okay. Do we have a clicker with this at all, or is it a hands-on job? Okay. Oh, there it is. Right, so this is super quick, but this is essentially a set of slides that we send out to Trust to prep people for the theoretical parts of the ANTT framework. And this has got the main nuts and bolts of the framework in. So, in a nutshell, it's important the staff understand aseptic technique.
Excuse me, but you're standing in the way.
Okay, right, I'll stand here. Actually, I might stand over here because that's where the button is. Okay, I'm going to move on a bit because... okay. Very bottom of the ANTT framework is let's have a clear microbiological aim of what we're trying to achieve. Lots of historical confusion over sterile, clean, aseptic, non-touch technique. ANTT very clearly says sterile is something you can't achieve in any air environment. You can have sterilised equipment, you open it up to air, it's at best aseptic. Clean is something you do for washing up and cleaning your clothes. Microbiologically, it's not a very useful determinant of asepsis. Okay? So the aim of ANTTs is asepsis, stroke aseptic. It means free, you're trying to achieve a procedure that is free from pathogenic organisms in sufficient dose to cause infection. So that's just a little bit of theory for people to kind of have as a baseline in their head and take them away from this concept of sterility, because you're not sterile even when you've got your sterile gloves on. Okay? So the aim is asepsis, stroke aseptic. Sterilised equipment is obviously really important. Cleaning is a very important part of aseptic technique too. But the aim is asepsis. There seems to be general consensus on that generally. So there we go. Asepsis. What type of procedures is ANTT designed for? Everything. So that's another clear message to people. This isn't something that sits in a hierarchy of sterile, aseptic, non-touch technique, clean. It's a framework for everything from brain surgery to sticking a plaster on your child's knee tonight in the kitchen, as I did yesterday. So it's based, so NICE defined ANTT as a particular type of aseptic technique with a unique practice framework. And this is what they were talking about, the unique concept of key part and key site protection. So the educational element and the practice element is based on teaching a concept of identifying key parts and key sites and protecting them with the other components of ANTT that we're going to talk about. You therefore need to have a clear definition of what a key part is. So it's not rocket science, obviously. I think we all know this. In IV therapy, for example, the key parts would be any of the critical parts of the equipment that are going to come into contact with the liquid infusion that's going to end up in the patient. Because if you contaminate those, you're likely to contaminate the liquid, contaminate the patient. Key sites, even more obvious, is essentially any portal of entry into a patient. Often disease made or treatment made by us, but any kind of hole, essentially, to be graphic, that can take microorganisms into a patient. There are some grey areas which we can't get into, like natural orifices, like our mouths and our noses, and the greyness around dentistry and all that kind of thing, but essentially any portal of entry that goes into a patient is a risk. What is the key part rule? So this is about as complicated as it gets with ANTT and the principles. You teach people to identify the key parts and teach them through the techniques that we use. And they have a couple of rules. The key one is aseptic key parts must never touch any other non-aseptic key parts or key sites. And that might sound really obvious and you're thinking, crimey, I need to go. But that can really help answer a lot of questions. When people are having these debates about whether a alka wipe should sit in the tray or now to the tray, you know, these nuances that people get quite fixated upon, it all boils down to that question very often. And obviously much more complicated questions too. Right, now practice needs to be efficient as well as safe. So there are two types of ANTT. Surgical ANTT, if you like, in old money, sterile technique. Doesn't look much different, it's been there for a long, long time. Predated ANTT, obviously. A large drape, everything is protected in one place, in one space. So if you like old money sterile technique, defined as surgical ANTT in ANTT. If a procedure is a lot simpler to do, then standard ANTT. For context, probably 95% of IV drugs are administered using standard ANTT. Some procedures are a little bit grey. Cannulation could swing either way depending on the complexity of getting that particular cannula in that particular patient and your competency. Similarly with urinary catheterization. Some procedures are a little bit more straightforward than others. Brain surgery tends to be surgical ANTT. What are the main two differences between, if you're trying to articulate the difference between standard and surgical? In a nutshell, surgical, one big critical aseptic field, everything's protected in, so therefore you need sterile gloves to maintain asepsis when you're handling all that equipment in that space. Standard ANTT, much more flexible, much more cheap if you like, much more quicker and simple, easy to deliver in difficult circumstances. The key parts are managed individually, and that's why the concept of having a packet like this, not your ruler and your pens and your phone, but the things that you need to use but don't need to keep sterile, aseptic, can be in a picture like that because you are looking after individual aseptic fields and you're maintaining that with aseptic fields and non-touch technique. There's a risk assessment in the framework on how to decide between the two. It's a simple question. Can I do this procedure easily without touching the key parts? You would consider things like how many are there, are they large, difficult to use, am I going to be here for 2 hours or 10 minutes? And if the answer is yes, it's standard. If it's no, it's surgical. That's been a big thing in ANTT because pre-ANTT, that decision was often made in subjective criteria. How old's the patient? What disease have got? How at risk are they? ANTT bins all that and says base it on the technical difficulty of achieving asepsis by not touching key parts and key sites, if that makes sense. Now there's always been three types of aseptic fields in aseptic technique, but just kind of one word, wasn't there? Aseptic field or maybe two, sterile field. But there are three and there always have been. So ANTT defines those because they're managed very differently. You do not manage the inside of a syringe packet the same way you do a big sterile drape in terms of how you handle that and manage that equipment. So there is a critical aseptic field, essentially a sterile drape, a microcritical aseptic field, which sounds a bit flash, but basically just means a small critical aseptic field. They have exactly the same qualities. You could argue that's more sterile in there than this once this has been open to a clinical environment for 30, 40 seconds or so. So these essentially have the same qualities. And then you have a general aseptic field. What does that? The general just sends a bit of a cue that it's not a sterile field, it's not an aseptic field. It's a procedure tray to promote asepsis. You're not going to rely on it and just drop your equipment on it and the key parts touch it, but you need something to port equipment around. Often in the sort of places we do these kind of procedures, but it's not strictly an aseptic field. It's a clean tray. Does that make sense? So your key parts are either being protected critically by a sterile drape or individual aseptic fields and promoted in wherever you're doing that procedure by having a disinfected tray or a pulp tray if you really have to upset me. Okay, so, and lastly, non-touch technique. ANTT didn't have a lot to say about that in some ways, in other ways it did. So, in a nutshell, ANTT says that non-touch technique is desirable doing surgical ANTT. So what does that mean, desirable? Well, it means that the whole reason you've chosen surgical ANTT is because that's a complex procedure. Let's be doing brain surgery. You might be there for 11 hours, you might have a few hundred key parts over that time to protect. You're not going to be able to practice in an individualised way without a very long operation. So, and the whole point you've done that is you couldn't do this procedure without touching the key parts directly. So you've got sterile gloves on. Now they're not infallible sterile gloves, but that's what we have. So it's desirable. If you're doing procedures where you don't have to touch the main key part, for example, like a urinary catheterization or a PICC insertion, you see a lot of people intuitively have sterile gloves on but not touch that major part that's going to be sitting in the patient indwelling for a while. They'll feed the PICC line in with forceps or from the individual sterile packet. So they kind of intuitively know that even though they've had to touch quite a lot of things with their sterile gloves on, that's the one they really want to protect. And they know the best way of not contaminating a key part is just not to touch it at all. So it's desirable. Now, standard ANTT is all about protecting key parts individually by non-touch techniques, so therefore it's mandatory. So you haven't got sterile gloves on, you've got non-sterile gloves, or no gloves maybe. And you're protecting things individually, so non-touch technique is essential. So that's a really, really quick whiz through the framework. It's 33 pages long, but that's essentially the elements of it. So it's not rocket science. And remarkably, just that little bit of structuring has made a huge difference and has filled a void, which is why ANTT has kind of embedded itself like it has. There's obviously a little bit more to it than that, but they're the key elements that people just need to understand. And when you get your head around that and you start to see procedures with ANTT glasses on, it starts to make a lot more sense of practice.